So here is my group, and we're going to get started. And the way we're going to get started is I'm actually going to set the stage by using some slides that we've used before. So we're going to spend a lot of time on CAR T-cell therapy and T-cell engagers. This is the part of the B cells that we're going to be looking at. BCMA agents, CD19, CD20. We're not looking at any of the other B cell therapies, which have been discussed actually in the autoimmune group. And this is important to understand. Where do the different therapies work? So this is the CD20, which would be rituximab, obinutuzumab, and it works from the pre-B cell out to the memory B cell, but does not affect the plasmablast or the plasma cell. And if you use an anti-CD19, that does get to the pro-B cell as well as the plasmablast. And if you use a BCMA, it gets everything, including the plasma cell. So that's what you would think about more and more efficacy. And the companies in the morning asked me to actually start with this, just reminding you about what the differences in the CAR T therapies are. So you have the original, the viral vectors. When we start, Diane's going to talk about actually the original study that was done with CAR T, and that was using a viral vector. And then we've used lipid nanoparticles, and now we're beginning to use CRISPR or gene editing. And Dr. Mies, who tried to steal a lot of our material when he was talking about the SPA group, was talking about a particular effect, a targeted effect with the TCE, with a T-cell engager. And that's actually what you really want to do. You want to affect the pathogenic B cells, not all of them. It's the pathogenic. So that will be the future. And then we started out with autologous. And again, Diane will talk about what the problem with that is. But that was the first ones that we used. Then allogenic, which is off the shelf. And the perfect one would be the in vivo, where you have the viral vector and you don't have to do anything. And then what can you affect? You can affect the T cell, the gamma delta T cell, or the NK cell, and we'll talk about all of those. So what's the difference? Right? What's the difference between these molecules? So if you use a CAR T mediated cell death, basically the ones that we have kill the B cells, all of them. All of them. And you'd expect the best effect. If you use a bispecific, or we'll actually even talk about a trispecific T-cell engager, it's almost as good, but not quite as good. And you can see there's some viable B cells, but a lot of them are dead. And if you use a monoclonal antibody, it works, but not quite as well. So if you take a look at this picture, here's rituximab. It's an anti-CD20 monoclonal antibody. It kills B cells, but there's still a lot left. If you go to the better one, obinutuzumab, which we hope will be approved for lupus, it kills many more, right? But there's still left. This is blinatumomab, which is a T-cell engager. It kills even more, but the CAR T kills them all. That's basically what you're seeing, and this is in tissue. So now we're going to start talking about the study. So Diane, why don't you start off with the Castle study, which obviously was the first one that was done.
Right. So this is a study that was reported by Professor Schett from the Erlanger group. It's the prototypical CAR T trial. And he reports on 24 of 52 patients in his cohort. And he followed the oncology regimen. So he utilized lymphodepletion and he used a single infusion of the construct. In terms of pharmacodynamics, the B cells depleted after a median of 7 days. All patients showed T-cell expansion, and the maximum expansion was seen in a median of 10 days. Their primary endpoint that they reported in this poster was safety. So they had no ICANS, which is very important. They did have 3 serious infections. They had some CRS and some ICAP. And they showed a remarkable, unprecedented efficacy. And this remarkable efficacy that was observed in this cohort sparked this widespread interest in CAR T and this significant expansion into research into different ways to use CAR T for our patients.
The CRS, the companies tell me it's just grade 1 or 2. It occurs in half the patients at least. It's not that easy for a rheumatologist in the office to treat. In the hospital, it's fine, right? But to the patient, it's annoying as well. So when the companies tell me it's not a big deal, it is a big deal, but it's treatable. And the other is I want to emphasize what Diane said. 9 out of 10 in Drs remission. And you're going to see, as you go through all of these, that's the number. A tremendous difference from what we've had before. All right, so that was the first one. But Laura, tell us about a second one.
Yeah, so this is another autologous anti-CD19 CAR T-cell approach, but the distinctive feature here is that it's rapidly manufactured. So it's less than 2 days versus the typical 3 to 6 weeks. So that's a great advantage here. And this was an open label phase 1/2 study in 21 patients with lupus. They had to have a SLEDAI-2K greater or equal than 8. And the reason why we're showing this slide is to show some of the typical results that we see when we're using CAR T-cell approaches. So what happens usually is that we have a peak expansion of those CAR T-cells about 2 to 3 weeks later. And then the reconstitution of the B-cell population is predominantly 60 to 90 days, but it's mainly naive B-cells. So that's the key thing here, that we get that desired immune reconstitution with a naive population and a marked reduction in your memory B-cell subsets and in your plasmablasts. When we're looking, though, at safety, there are common safety signals that we're seeing across these studies. So we see a lot of the lymphodepletion-induced cytopenia. So that's very common, of course. And we see also commonly CRS, predominantly grade 1 and 2, but in more than half of the patients. Thankfully, little ICANS, but some ICANS reported across the studies, and SAEs in the form of infections. But the remarkable thing is the great efficacy and response we see across all the lupus activity measures supporting these efforts with CAR T-cell therapy and showing similar safety concerns across all these studies.
So when you get to the slide deck, when the companies get the slide deck, you get the appendix in the new molecule group. The first slides in the appendix are the 30 studies that we looked at. So rather than doing 30 different studies, we put Nash to work so he can put it together for you.
This was to help Philip Meese out so he knows where we're going. So if you'll see the drug companies on the left-hand side, we distilled 30 abstracts down to this number. You'll notice that they're all open-label studies. They're all very small numbers of patients. Most of them make a CAR T-cell. One of them uses the NK cell, and that means you can get it off the shelf. You can get it from cord blood, from pluripotent stem cells, from NK cell lines, and that makes it allergenic. There's one other, the Fate therapeutic is allergenic. Their target is nearly always CD19 because you want to leave the plasma cell alone, as we've heard. And one of them is a dual 19 BCMA together. The usual diseases, lupus, systemic sclerosis, and idiopathic inflammatory myositis are the ones and lupus nephritis are the ones that are being tested. They all have been using lymphodepletion, which is the big bugbear that we'll talk about later on, except the Fate therapeutic had one patient with no immunodepletion at all, and the other patients left off the fludarabine, which is genotoxic in young females, which is the bulk of this patient population, and they either had cyclophosphamide or bendamustine. The safety we've mentioned, pretty much all of them get some CRS. Very few get ICANS, but it is reported, and ICAT is quite common, which we can also discuss. So the prototype took 3 to 6 weeks to manufacture. The new platforms are cutting it down to 2 days. The Cabaletta drug is fully human. The rest are murine, and we worry about anti-drug and anti-CAR T antibodies down the line is an issue with murine components. And you've got 2 or other methods, the next platform, and also the CRISPR technique of the other allergenic Fate molecule, which allows you to be really precise in your engineering. avoid T cell exhaustion, make the drug last longer and survive longer. And the bottom one, the allergenic NK, it's off the shelf, but you need 3 doses. Over to you, Roy.
Okay, so we've talked about safety. We've talked about the CRS. We've talked about the ICANS, the ICAT, SAEs, the serious infections because of lymphodepletion. But there's something new. Alvin?
Yeah, I like Diane's term. You know, we have unprecedented efficacy with these drugs. But with these drugs, they come with a side effect profile that we're seeing. And like Roy said, this is new. So from the Erlanger group, they report a new set of toxicities that we're seeing with these agents called LICATs. You see them defined here. So they reported on 30 patients where they had 54 events of these kind of activities that you see here. Here's a key thing. Look at, focus your eyes on the salmon-colored box on the right. These events happen pretty quickly at a mean duration of days between 12 to 20 days. But they also resolve pretty quickly as well, see, within 7 to 14 days. In the grades here, you see that some spontaneously resolve, but some did require glucocorticoids that were used. Here's one of the other things that we see in this set. Look at the bottom, the organs that were involved. If people had skin targets for the disease activity, that's where we saw the flare. If people had kidney involvement from the disease activity, that's where they had the flare. So they happen quickly, they resolve spontaneously, but it seems to be involved in areas that the disease is targeted here as well. We had a lot of discussion in the group about what was the cause of this. Is it antibodies against the product? Is it disease activity? We talked to Dr. Shetton. He assumes it's coming from B-cell necrotic tissue, that fragments of these B cells are triggering activity in the organs where the target is. So exciting data, but we got to balance the efficacy with the safety.
And Professor Tanaka, you had a thought about that it's the necrotic B cell in the tissue.
Yes, distribution of organ involvement in each disease appears to be interesting, as shown in the bottom of the table. So if assumption that necrosis of B cells induce reactions, LICATs may be a good to predict the responsiveness to CAR T therapy.
Yeah, so it kind of makes sense. You're killing the B cells in the tissue, you get a reaction that then the B cells, this actually should be in the tissue. I don't know if it is, but Al, tell me, is it?
It may or may not be. So, Roy had mentioned earlier that a key distinguishing feature of CAR T cells, its ability to deplete deeply, i.e. at the tissue level. So what happens after that is in the peripheral blood's been shown that B cell resetting occurs, that naive cells come back. So why we're showing the 3 patients on the left side here is that this is the bone marrow compartment that's being examined, both pre and post CAR T cell, CD19. And I want to focus on the bottom flow cytometry plots. This is post CAR T cell. And you can see in 2 of the patients that most of the B cells are gone. Maybe there's some early repletion in patient 1. But the really important example here is in patient 2. There is almost full repletion. But the B cells there are not the same B cells as before. They are all naive. So now we have tissue level evidence that B cell resetting may be occurring there too, and most likely going to be occurring in other tissues. But the effects immunologically of CAR T cells doesn't stop there. And this is shown on the right side here, where pathway analysis on single cell RNA-seq peripheral blood T cells was performed. And numerous programs are changed, but most importantly and most robustly, the interferon signature tends to disappear. So Roy, I think this is really important because not only has B cell effects in terms of this B cell resetting, but I think it likely represents a more global reprogramming of the immune system, and here it is shown with T cells.
We think we filled the Koch's postulate for autoimmune disease. Certainly the oncologists have done it because they've been using this for years. One of the points that we've made is, I think Peter made this, we've used the oncologist's way of treating with lymphodepletion, right? And we're going to talk a little bit about that later, whether or not we really want to do that. Let me go back. So we showed that Yerokshett says it's one and done and perfectly safe. And it's not one and done, not in everybody, right? And it's not perfectly safe. We've shown you some side effects. The question is, what happens if you treat and then the patient loses effect?
So the new molecules group has never done an N of 1 case report, but with this generation, we are here to change that.
Unlike other sections.
All right. not just because we can be contrarians, but I think this is actually an important illustrative example of how the CAR construct itself actually can lead to downstream immunologic issues that are clinically important. So this is a female with a refractory ASyS myositis, got CD19 CAR T cells, went to remission, but relapsed after 9 months. Got the same CAR T cell again, and it did not engraft. So just to complete the story, received an anti-CD8 monoclonal antibody. This is going to be depleting plasma cells, went to short-term remission. And then when BCMA CAR T cell therapy was available, received that and has now been in drug-free remission for now up to 12 months, according to Garrick Shed. So, why would this occur? Peter had mentioned anti-drug antibodies, anti-CAR T cell antibodies, and this is actually quite common in patients that receive CAR T cells. In the oncology world, anti-CAR T cell antibodies are observed in 5 of the 6 FDA-approved drugs in that space. And in the Erlangen experience, 80% of all CAR T cell recipients actually develop anti-CAR T cell antibodies, but they are non-neutralizing. So this is not the explanation. What is the explanation? So this is on the third line in the top. They found T cells reactive to the CAR construct itself. And I think this is actually going, the epitope here is within the CD19 binder. So the older generations of CAR constructs used a binder called FMC63. This is a murine protein. So you can easily imagine it being immunogenic. You develop anti-FMC63 T cells. And then when you try to give them those T cells back again, the CAR T cells, of course, they're going to be eliminated. The newer generation, as Peter had mentioned, from Kyverna, Cabaletta Bio, these are either fully human or humanized. And this is going to completely eliminate that issue. So, Roy, I think, this is an important factor, given that the cost and complexity of giving CAR T cells with this type of therapy, like if you have to redose, this is an important consideration.
So the consideration is you would change mechanism?
So I think you have to go now to, you don't have to change mechanism. You could probably still stick with CD19, but you're going to at least want to go to a human or fully humanized or fully human construct.
But we don't know the answer to that because that study has not been done, right? Can you use one CD19 and then another CD19, where they did here a CD19 and then a BCMA? Or could you use a CD19 and a CD20 or a CD19-20? We don't know. I should point out, and I think that Peter did point out, that in all the studies that we've done in AID, it's probably 100 patients, of which you're maybe more, but Dr. Shed has 50, right? So it might be 100. It's not a lot of patients. Okay. T-cell engagers. Peter, tell us about the first one that we've looked at.
There mustn't be any lupus nephritis patients left in the US because 5 companies have come to Australia wanting to do CD engager studies. This is the first one borrowed from the oncology experience in lymphoma, so it's an available drug. It's a single strand, it's murine, and because of the experience in oncology where they had a very high incidence of CRS and a very high incidence of ICANS, they were very cautious in the way they gave this drug and have an interesting dose escalation profile you can see top on your right. This needs to be given as a continuous intravenous infusion over 5 days, increasing the dose. Therefore, you need a pre-med, and they use hydroxycortisone and an antihistamine, but it depletes very effectively. It knocks antibodies down. It knocks B cells down. You can see there on the left. It induces the T-cell activation differentiation, and they've studied it in systemic sclerosis, also in JO1 myositis, and again, they've got remission rates of 100% in those 3 patients, glucocorticoid-free myositis. So side effects you'd expect, B-cell depletion you'd expect. This is the first generation of the T-cell engagers.
Yeah, so I want to reemphasize that in these 4 patients, you see it's an IV infusion every single day, right? For this molecule, and they adjusted the dose. As they got more comfortable, they increased the dose. So this should be cheaper. this should be actually more convenient than CAR T.
Don't have to put them in hospital.
You
Don't have to have
theoretically, you don't have to put them in a hospital. We have to prove that.
no lymphodepletion. These patients were hospitalized for 72 hours with each infusion.
No lymphodepletion, as you pointed out, and there should be less safety issues. So maybe not as potent as CAR T, almost as potent, and maybe easier. But then we have another one. So this is another generation. Yoshi, do you want to talk about this one?
Yeah, Vilunatuzumab is a single chain bite, but this is mosunetuzumab is humanized IgG1 bispecific antibody binding to CD20 and CD3 with 1.1 to 1 ratio, which results in killing of B cells directly by T cells. Showing the dose escalation study in E3, 15 patients were set in the non-fractioned cohort with 1.6 or 5 milligrams of these antibodies. And after the DLT assessment period for 21 days, they were set in the fractioned cohort with 15, or 45, or 60 milligrams of these antibodies at day 8 by the SC administrations. Right panel is changing B cells. We could see the good dose dependency in the mosunetuzumab, especially in the highest dose, 60 milligram. We could see the marked reduction in B cell from periphery. And in terms of changing 3-2K, as in the right panel, 4 of 6 patients achieved more than 4 reductions 3-2K, but still point at 4 or 6 without 0. So I'm not so satisfied with this result, and much better T-cell engager may be required or expected.
So we discussed that. So this is truly a phase 1 dose ranging study, safety. And we would have expected better efficacy. But efficacy really wasn't the end point. So we'd have to see, now that they've done dose ranging, what would happen if they did greater number of patients? How effective would it be? And we think that it should be more effective than blinatumomab, but we'd have to see. The other point was, this is sub-Q. Day 1, day 8. Doesn't continue with IV. Nice for the patient. But because of that, you see ISRs. There were ISRs in almost everybody, which you can deal with. And then 1 grade 3 neutropenia. So safer than the CAR Ts that we've seen, but how effective will it be? What about other approaches, Alvin?
So, I mean, what the group has described thus far is just a tip of the iceberg. So imagine molecules that's going to get a better response in getting rid of the B cells. And so some novel approaches here. We talked about a bispecific. What about a trispecific? A molecule is going to bind to a T cell, bring it in close proximity to a B cell, but now I'm going to tickle that T cell by engaging CD28. I'm going to turn that T cell on to allow it to target that B cell effectively. What does that translate into? A rapid and a deep depletion of the B cells you see there. This morning at the late breaker, the Chinese group would describe a few patients that had lupus. Guess what? 100% of them had a SRI4. They decreased the proteinuria. They improved all the other parameters that we're looking for in lupus. So it's very kind of exciting times. We do see some expected, side effects that we described with the B cell targets. Down below, there's another target. Remember?
Wait, hold on. That was fine. But Yoshi said something, right? You had a problem with this one.
Yes, the CD28.
Right? The CD28.
Yeah, certainly. But we have to remember the tragedy that CD28 and or CD28 agonistic antibodies induce serious cytokine storms, and which are required the ICU care unit requirement. So, which was reported in 2006 from London. So we have to remember that tragedy.
So Yoshi pointed that out because, what do we know? He knows everything. And when the presentation was done today, that question was actually asked. What about the CD28? And what the presenter said was the CD28 is hooked on in a way that it mitigates that problem. Now, Alvin is an MD PhD. I'm not. I asked him, I said, what does that mean? And he said, I don't know. But theoretically, they have done something. We have to look further into it to mitigate that problem. What about the other molecule, which is really interesting?
Another unique molecule. So remember, B cells go into plasma cells and make autoantibodies. In rheumatoid arthritis, one of the autoantibodies are anti-citrulline and proteins that we see here. So now they have a CAR construct that goes to those citrulinated peptides here. And again, here's one of the key things about this kind of construct, getting rid of those autoantibodies that we think are pathogenic in rheumatoid arthritis. Look at that first sub-bullet point. There's no cell destruction. There's no lymphodepletion. Like Peter said, I'm worried about putting them on these chemotherapies. They can get CMV, they can get all these side effects. So having something without lymphodepletion is going to be really key. And again, these autoantibodies in the presence of the synovium, they really do play a role. So this is kind of exciting to be able to have another molecule like this.
Yeah, so there was no efficacy data in this. However, someone told me, who I'm sure is correct, who's in Treg, he's actually doing the study, he had one patient, and really had a good effect. But we'll see, all right? And that's one. Okay. So what we've done is we've actually had people just talk about each slide. We haven't had a lot of interaction because I wanted to save it for here. So what we did was when we put this slide together, in terms of efficacy in B-cell depletion, there's no question CAR-T is better than T-cell engager, better than a monoclonal antibody. I showed you that previously. Clinical efficacy, there is also no question that the CAR-T is better than the T-cell engager, which is better than a monoclonal antibody. Not perfect for the CAR-T, but close. Tolerability, to me, that's the CRS, it's the ICANS. CAR-T is a little bit more problematic than a T-cell engager, which is a little bit more problematic than a monoclonal antibody. In terms of ease of administration, so this is how do you have to do apheresis? Is it off the shelf? The whole mechanics. CAR-T is very complicated. The T-cell engager is much less complicated, and monoclonal antibody is not complicated at all. In terms of cost, that one doesn't mean it's the best. It means it's the worst, right? And the T-cell engager should be much, much cheaper. Not as cheap as a monoclonal antibody, but it should be much, much cheaper. And then the question is payer accessibility. So I decided I'm going to do CAR-T. Phil has already said he wants to do CAR-T. And we have a patient that we identified. Will a payer pay for it? Will a payer pay for it? And the other question was, which came up already, is access. Can you get a hospital, if you can do CAR-T, where you can actually get the patient in and a hematologist? And then the other question is, who should be treated when? So we have here the concerns that we talked about, and you can look at that. But I want to ask the panel. I'm going to start with Diane. So we spent a lot of time talking about CAR-T, T-cell engagers. What's your gestalt?
I think they're very interesting. I think you have to pick the correct patient, though, because in certain diseases, it seems like it would be a very good idea that the disease warrants a treatment of this significance and this risk. And in other diseases, you may not need that. And I think you have to look at each patient individually and figure out what they've been on before and what their actual risk is if they need to be, if they need something like CAR-T or T-cell engagers, or if they need some of our more traditional tried and true therapies. So I think it's going to become an individual decision per patient based upon their disease manifestations and their prior therapies.
Yoshi?
Yes, CAR-T is fantastic because it induces reconstitution of not only B cells, but also immune systems or autoimmunity. However, I may have two additional concerns. First, CAR-T is not off the shelf, so it takes 2 to 6 weeks to prepare for patient. If a patient with life-threatening come to us, we can't wait the patient. So in such a case, CAR-T cannot be used. Next point is we usually get the informed consent from each patient based on the evidence of placebo control phase 3 studies. However, judging from the hematologic malignancies, we have to think about what is a better placebo controlled or comparator for the CAR-T therapies.
Alvin?
Everybody has concerns, but I go back to the future. So in 1988, when we got methotrexate approved for rheumatoid arthritis, we started 5 milligrams a week, and in 3 months we went to 7.5, and then we went to 10, and all the stuff because we worry about the side effects. 1998, we had a TNF antagonist. We worry about immunosuppression. We worry about TB. We worry about infections. We use them like water. So now EULAR has told us that prognostic factors should not be even accounted. You got a patient with active disease. I'm going to wait till they get a foot in the door of the dialysis center. I'm treating them up front, and I'm going to use whichever of these agents I need to get them under control.
I don't know why Alvin's so wishy-washy. Peter?
So what's the excitement with CAR-T? Your alternative is a lifelong immunosuppression on MMF and a biologic and steroid, or 4 years of drug-free remission. We've never had anything like that in rheumatology before. So that's why people are so excited about CAR-T. And I think I'm a bit sick of case series which teach us nothing. They might be okay to get approved by the FDA, but we need some controlled trials that answer the questions we need. The lymphodepletion question, some of the other issues that we've been talking about. So I think it will be the future for the right patient, and I think that we should get on board.
Laura?
Yeah, so I think everything we do to decide on therapies for our patients is that balance of efficacy, and we haven't seen anything as efficacious as this. So it's game changer. It's a game changer. But we have to also balance it out with the safety signals. And I think as we gather more data, of course, we want that control arm. But the more cases we get, we'll feel more comfortable in when to use, what's the specific patient population for each of these conditions, and how we can tweak things around rheumatology and not oncology protocols. What do our patients really need?
I'm going to skip out. No.
Fair enough. So, I'm still struck by this trend between the efficacy of B-cell depletion, clinical efficacy, and tolerability, right? With CAR T-cells, best deep tissue depletion of B-cells with the best efficacy data, also the worst tolerability. CAR NK engagers, not as good at B-cell depletion in the tissues. The clinical efficacy isn't quite as good, but it is more tolerable. So it kind of makes me think about, like, what does the next generation of each of these agents look like, right? So for CAR T-cells, how do we, engineer the CAR construct potentially that will mitigate and reduce the amount of cytokine release syndrome, for example? For CAR NK, how can we engineer improved cytotoxicity within these NK cells so they match the killing power of T cells? The engagers, are we able to create an engager that allows for deeper B cell depletion in the tissues, right? So these are the next things I'm thinking about.
So you raise an interesting point. So if you, 2 years from now, 3 years from now, 4 years from now, you can develop a way to determine what B-cell line is pathogenic in an individual patient with SLE or scleroderma or what, and you had a CAR-T that was absolutely specific, just like the psoriasis, the SPOT group showed, or that we've showed before with APL, that would be much better, wouldn't it? Right? That would be the answer to what we're doing. But let me ask this question. Yusuf brought this up. He said, these are very small studies, and studies are very different than real life. I don't know that I agree with him in this context. How would you do a study with a CAR-T that would actually answer Yusuf's question? So if you did 100 patients with a molecule, open label, 90% achieved DORIS remission sustained for 4 years off immunosuppressants, off steroids, all right? You might have a little CRS and ICANS and all that. Would that be sufficient? Or would you need to, or do you think that you need to do a controlled comparator study, right, showing the CAR T versus what we have now, or the CAR T versus a TCE, what would you want to do? So this is, you're going to answer the question, mono is great or need a combination. But if you say you need a comparator, but if you say you need a comparator, you have to tell me the comparator. So Diane, I'll start with you again. Is mono fine or do you need a comparator?
Well, as rheumatologists, we're more familiar with trials that have a comparator. I think because of the large effect size, we may be able to do this without a comparator. We may be able to use historical data.
Can you answer my question?
Yeah.
What do you said both, right?
I did, yeah.
So what would you prefer? Would you prefer?
I prefer with the comparator. I don't know if you're going to have enough patients to that. And the comparator would be...
What would you like to see as the comparator?
It would be great to see a T-cell engager as a comparator, but I think it's more practical to have a monoclonal antibody.
Yeah, I think it's difficult. Yoshi, mono or a comparator?
Yes, we need. We need comparator or balance between safety and efficacies. So we need a balance between safety and efficacies. We have to confirm that. So that's why we need comparators.
You need a comparator. What's a comparator?
Maybe CD19 or CD20 cells or accumulation of huge data of SLE patients.
Alvin?
No comparator. I need this drug on Monday.
Today's Saturday. Tomorrow's Sunday. You don't want a Sunday? You give me 2 days. Okay. Peter?
So 2 issues. One is to get it approved by the FDA. You may not need a trial. You might just need 100 people. But to answer the community's questions about how we can continue to use it better and safer, yes, I would recommend trials. And either a CD monoclonal, which will be the cheapest comparator, or a CD engager with tissue to prove deep B-cell depletion would be the best alternative.
Laura?
So I think the comparison, of course, is the ideal scenario, but I would still use this therapeutic approach if it was an open label showing that level of efficacy that we're seeing in these cases.
Al?
If we still have study patients to do this in the future, I would love to have a CD19 monoclonal antibody because I feel like that choice for patients is going to be the one we most likely are going to be using. And this is going to give them the best data in terms of balancing risk and benefit.
So I actually don't think that Al's statement was funny. It wasn't. There were more companies doing studies in lupus nephritis than there were patients with lupus nephritis. I think that what Peter said actually made the most sense. We talked about this, and the group really thought that was true. The FDA will decide what the company needs for approval, whether it's a comparator or whether it's just a large open-label study, because the effect size is so great, all right? And I don't know what they're going to do. I wouldn't be surprised that they say you have a large open-label study, it would be fine. I wouldn't be surprised. But for the rheumatologist, right, to give us confidence, it would be a comparator study against the CD19. If a TCE is approved, can I do a TCE versus a CAR T? What would I rather do? Because right now, I think we would say the patient that Yoshi was talking about who had active disease, you go to monoclonal because it's easiest, and then you might do a TCE because that would be easier than a CAR T. So many things to think about. Okay, now with that, we have a few more slides. So this is in Pitorin. It's a TLR7/8. Yoshi?
TLR7/8 is involved in the innate and adaptive immunity and play a central role in the pathogenesis of SLE. So this is a very important molecules. So EULAR study is phase 2 study of toll-like receptor 7/8 inhibitor and Patron in patients with lupus SLE. 354 patients are randomized to Patron 25, 50, 100 milligram BID or placebo. And primary endpoint is vehicle response at week 24. As shown in the right panel, 25 milligram appears to be significantly better than placebo. However, those dependency cannot be observed. In terms of vehicle response combined with clinical meaningful glucocorticoid reduction, again, we could not see the good dose dependency could not be observed. But the drug rapidly reduced the interferon gene signatures and if patients have high interferon gene signatures or high skin eruptions, this drug appears to be better, or she observed the good dose dependency. So we have to think about how to treat or estimate these drugs.
Yeah, so the question that came up was there was no dose response, which raises the question whether or not the lowest dose is actually a high dose. Would a lower dose give you dose response? The other question that I asked Eric was, what about the SRI-4? Was that positive? And from the stage, you said, I can't answer that, but speak to me afterwards, which I did. The SRI-4 was positive. So this should be a major pathway. We can't have new molecules without rheumatoid arthritis. PD-1 agonism.
Patients who have active rheumatoid arthritis have been found to have high amounts of PD-1 positive T cells in their synovium. So we're going to present J&J's molecule, which is a humanized IgG monoclonal antibody that agonizes and depletes PD-1 positive T cells. They did a double-blind randomized controlled trial in patients who were non-responsive to conventional DMARDs but had not been exposed to biologic or targeted synthetic DMARDs. What they found was that there was no difference between placebo and the drug in safety, but they also found that in the ACR20 and the DAS28, so they did not show efficacy, which was somewhat disappointing. There's two other agents that also harness this pathway. Lilly had an agent that gave a deeper depletion, and did show efficacy, but they've since halted their program with this agent due to some safety and efficacy concerns. Anaptys Bio also has an agent in this pathway. They've released some top-line data, but they haven't released their full data set. So it'll be interesting to see when that data comes out if this pathway turns out to be a pathway we can use in RA therapies.
Right. And one of the reasons why this may have failed, the molecule didn't reduce the PD-1 positive cells as much as the Lilly drug has shown or the Anaptys drug has shown. Okay, and then we're going to end with FcRn, and Laura's going to talk about two studies.
Yes, so this is a study using efgartigimod. So this is a neonatal Fc receptor inhibitor in myositis. And as an antibody that has a high affinity for the neonatal Fc receptor, what it does is that it interferes with the recycling of IgG. So with that, you get lower autoantibody levels. So this was in a phase 2/3 RCT in 89 patients with myositis, with the endpoint being TIS at 24 weeks. And we see there on the right that the study was positive. It did show efficacy meeting its endpoint. The degree, the magnitude of that effect seems modest. But when we look at the secondary endpoints, we clearly see very clear distinctions amongst the treatment and placebo arms. And looking at the side effects here, there was no increase in SAEs with the treatment arm, but we saw more commonly were ISRs. So showing some efficacy here in myositis. And this same molecule was actually studied also in Sjogren's. So this is now the second, drug using this mechanism in Sjogren's. So this was in patients that had seropositive Sjogren's, so they had to have a positive SSA and an SI greater or equal than 5. This was 34 patients, and here we see again a positive result with a markedly increased response rate measured through the CRESS composite index. And when we're looking though at the different components there, we did not see a difference with the ESPRI. However, these patients did not have an ESPRI requirement for entry into the study, so that's not unexpected. What's expected, though, and nice to see, there is the marked reduction there in RF and IgG. So another positive study, supporting this MOA in patients with Sjogren's.
So with that, thank you, and we will conclude.